Welcome to this space dedicated to the dissemination of scientific knowledge, designed for specialists, general practitioners, and students, as well as the general public interested in health. In this edition, we present a detailed analysis of the study titled Secondary B-Cell Non-Hodgkin Lymphoma, involving the breast, imaging evaluation, a fundamental work for understanding the approach to these tumors, which, although rare, represent the largest group of metastatic neoplasms to the breast. This research was published in 2005 by Dr. Ernesto Roldan Valadez in collaboration with a distinguished team in Mexico. Throughout this video, we will explore how the team analyzed the clinical and radiological characteristics of this lymphoma through the case of a 78-year-old female patient whose clinical presentation included palpable masses and systemic symptoms that posed a significant diagnostic challenge. We will also identify key findings regarding the appearance of these lesions in mammography, ultrasound, and computed tomography, as well as the critical importance of tissue biopsy to confirm a definitive diagnosis, given that radiological patterns are often nonspecific and indeterminate. Legal disclaimer: this material is for educational and scientific dissemination purposes only. Its goal is to democratize access to the knowledge generated in specialized academic publications. Due to the dynamic nature of medical science, the information presented reflects the data available at the time of the original article's publication and may be subject to subsequent updates. Not medical advice. Under no circumstances does the information presented constitute a medical recommendation. The graphic resources used are only a representation of the article presented and are not completely accurate to human anatomy. For more information, you may pause the video.
Welcome to This Explainer. Today we're diving into a really fascinating clinical detective story. We'll be walking through a documented case of secondary B-cell non-Hodgkin's lymphoma of the breast. It's honestly a masterclass in what happens when a patient's systemic symptoms point in a dozen different directions all at once, and standard imaging reaches its absolute limits. Let's get right into it. Here is our roadmap for today. We're going to cover a rare breast malignancy, the patient's presentation, the imaging investigation, the definitive diagnosis, and wrap up with some key clinical takeaways. Section 1. A rare breast malignancy. 0.1%. To put that into perspective, out of all the malignant breast neoplasms that clinicians encounter, primary and secondary lymphomas account for merely 0.1%. Think about that for a second. For every 1,000 breast malignancies, maybe just a single one is a lymphoma. It's almost never the first thing that crosses a doctor's mind when they discover a breast mass. And even if we zoom out to look at non-Hodgkin lymphomas that pop up outside the lymph nodes, what we call extranodal cases, breast involvement is still exceptionally rare. It makes up only about 2% of those cases, with 98% occurring in other extranodal sites. Actually, to give you an idea of just how rare this is, only about 300 cases of primary breast lymphoma have ever been reported in the entire medical literature. Section 2. The patient presentation. So let's meet our patient. We're looking at a 79-year-old woman presenting with unquantified weight loss, a general decline in her overall health, posterior left chest pain, and painful swallowing. But when they actually did the physical exam, the clinical picture got incredibly complicated. She had multiple hard, completely painless 2 to 3 centimeter nodules on her scalp, infiltration in her soft palate, pallor, and, this is the real kicker, a palpable, painless mass in the upper inner quadrant of her right breast. It's like a giant puzzle where the pieces don't quite seem to fit together. Well, the clinical team ran some labs, and the markers were honestly alarming. Her uric acid was sky high at 13.54. Her beta-2 microglobulin was more than 4 times the upper normal limit, and her lactic dehydrogenase, or LDH, sitting at a whopping 2146 units per liter. These highly elevated markers are massive red flags. They're telling us that a rapid, aggressive cellular turnover is happening. We are definitely dealing with a systemic process here.
Section 3. The imaging investigation.
Let's take a look at the translated descriptions of her initial imaging. Her chest X-ray showed a widened middle mediastinum, which basically suggests enlarged lymph nodes sitting right in the center of her chest. And when they did a mammography, they saw bilateral increased tissue density that was noticeably worse in the right breast, causing an asymmetry. Interestingly enough, she also had enlarged lymph nodes in both armpits, but radiographically they actually looked benign. So we've got increased breast density and mediastinal widening. Talk about an ambiguous diagnostic picture, right? Is this breast cancer spreading to the chest, or is it something else entirely? To get a clearer look, the team ordered an ultrasound and a CT scan. The breast ultrasound showed multiple solid nodules with ill-defined borders, along with swelling right around the lesions and increased blood flow. Meanwhile, the chest CT scan uncovered something massive. I'm talking about an 8 by 4.7 centimeter solid mass in the mediastinum, literally wrapping around major blood vessels. So the really crucial takeaway here is that we have widespread disease. There are tumors in her breast, her chest, and, if you recall from the physical exam, her scalp. Now, you might be wondering, why couldn't they just look at all this imaging and confidently say, yep, that's lymphoma? Well, because breast lymphoma is an absolute master of disguise. On imaging, lymphoma often presents as round or oval opacities that visually mimic totally benign processes, like simple cysts or fibroadenomas. On the flip side, typical breast cancermas usually show up with microcalcifications or a desmoplastic reaction, like skin retraction. Lymphoma generally just lacks those classic carcinoma signs. And that brings us to the radiographic exclusion. The absolute absence of microcalcifications and a desmoplastic reaction is what keeps this diagnostic mystery alive. Think about it. If the radiologist had seen those elements, they probably would have just pointed toward carcinoma and called it a day. But they were missing, leaving the imaging totally indeterminate. Section 4. The definitive diagnosis. I actually want to read this quote directly from the source material because it really is the linchpin of this entire explainer. Quote, "The most critical aspect in the workup of a breast mass is the tissue biopsy, since radiographically lymphomatous lesions are indeterminate." Unquote. When your high-tech imaging just gives you vague, gray blobs that could be literally anything, direct tissue analysis is the only path forward. You absolutely have to get those cells under a microscope. So, the medical team went to work. Step 1, target acquisition. They took tissue biopsies from her breast, those nodules on her scalp, and her bone marrow. Step 2 was the morphological analysis. The pathologist looked and saw that the bone marrow was hypercellular, just packed with cells featuring large active nuclei. And finally, Step 3, the ultimate key that cracked the case, immunohistochemistry. They used special stains to look for specific proteins. The tests came back CD3 negative and CD30 negative, but critically, they were CD20 positive. Why is that a game changer? Because CD20 is the hallmark marker for B lymphocytes. And there we have it. The puzzle is solved. The diagnosis is secondary B-Cell Non-Hodgkin Lymphoma. This is a systemic lymphoid malignancy, proven by that CD20 positive marker that started somewhere else in her lymphatic system and aggressively metastasized, infiltrating her breast tissue, her scalp, and her chest cavity. The biopsy completely cut through all the ambiguity of the imaging and finally gave the oncology team the exact target they needed to start treatment. Section 5. Key clinical takeaways. All right, let's wrap this up with your diagnostic pearls from this explainer. First, always remember that breast lymphomas, whether primary or secondary, are exceptionally rare. Second, you just cannot rely on a mammogram alone here. The appearances are highly nonspecific, and they easily mimic benign masses. Third, use the negative space. The absence of microcalcifications is a major clue that you might not be dealing with a typical carcinoma. Fourth, if you spot prominent lymph nodes combined with a rapidly growing breast mass, your suspicion for lymphoma needs to spike immediately. And finally, the biggest takeaway of the whole shebang, tissue biopsy remains the absolute, unavoidable necessity for a definitive diagnosis. You cannot skip it. So I'll leave you with this final thought and question. When radiographic patterns are totally indeterminate, when the imaging mimics the mundane and tells you an incomplete story, will you remember this case? Will you remember to look closer, trust the systemic clinical clues, and demand the biopsy? Because as we've seen today, that is quite literally the only way to uncover the truth. Thanks for joining me for this explainer, and stay curious.
The reference for the article from which this information was extracted is displayed on the screen. Thank you very much for your attention and for joining us until the end of this analysis. If you found this review helpful, we invite you to share it with colleagues, residents, students, and anyone interested in these topics. Don't forget to subscribe and turn on notifications. This material is for educational and scientific dissemination purposes only.